Psychiatric emergencies. Self-harm. How common is it as in presentation in NHS? It's a very common presentation to the emergency department in UK. So self-harm, they injure themselves. It can be an cut to the wrist, or it might be an cigarette burn, or it might be an just a stab injury they had it to one of the limbs. It's a self. So they inflicted the injury on themselves. So the two things are important. The injury itself, what they are having. So it might require some medical attention. So injury, one thing. Another one is the psychiatric evaluation. Why did they self-harm themselves? These are the two main parameters what you need to look out for in this. Both needs to be treated simultaneously whenever possible. What do I mean by simultaneously whenever possible? So sometimes they may not be possible. They might be having life-threatening injuries. AV might be compromised. At that point of time, you cannot do a psychiatric evaluation. Sometimes they might be under the influence of alcohol or under the influence of some illicit drug. So you cannot do a psychiatric evaluation at that point of time. If it permits, it is always suggested that do a psychosocial assessment whenever possible along with the medical treatment. Sometimes the patient might refuse for a psychosocial assessment. They might want or only seek a medical attention. So you're just giving the medical advice or medical treatment, what is required for the injury, what the patient is having. These patients are very high risk of flight. For that particular reason, a preliminary psychosocial assessment, a triage needs to be done. How does it appear? How does the person appears? How tall is it? Or what is the build? What color of shirt he is wearing? What color of trousers he or she is wearing? That is important because if the patient leaves the department without informing, then to trace back it will help. For that particular reason, you need to make sure a psychosocial assessment is done at the track itself. Patients who have to wait for the treatment, there's a long waiting time. Make sure these patients are in a safe, supportive, and minimal stress areas. If the person who has self-harm is less than 16 years of age, it is recommended that the child is assessed by a child psychiatric before they leave the department. So someone who comes with a self-harm, is it safe to discharge? It depends on the scoring known as sad person scoring. Though the NICE doesn't recommend a sad person scoring, but previously in the exam, they have been tested about the sad person score. So you need to be aware of sad person score. Sad person score itself is a mnemonic. Sad person itself is a mnemonic, where S stands for sex. So male sex are more prone for self-harm. Age, extremes of the age, less than 19 and more than 45 years. Depressed or hopeless. Depression might not be a diagnosis which is already present. So there might be depression which is undiagnosed, suggested by a decreased concentration, appetite, sleep, libido. So this is all suggestive of a depression. Or he or she might say, yes, I am a known case of depression. I am on some medications, or I'm known case of depression. I stopped taking medications. Those kinds of things will be said. Depression and hopelessness are closely interlinked to each other. Any previous attempt or psychiatric care? Any previous attempt for what? Any previous attempt for suicide? Any previous attempt for self-harm, basically? Any previous inpatient or outpatient evaluation or treatment by a psychiatrist? Excessive alcohol or drug use. Excessive alcohol they are taking. So anyone who is a chronic alcoholic addict or anyone who consumes any illicit drugs, they are at risk of self-harming again. Rational thinking loss. That means they cannot think rationally like you and me because of an underlying cause. For example, they are having schizophrenia. They cannot think rationally because of the auditory hallucinations. Or they might be having some brain injuries which doesn't allow or permit them to think rationally like a normal human being. Any recent events, for example, recently got divorced, or it's an anniversary of them divorce, or widowed, or recently got separated from a relationship. So recently it has happened, or it is an anniversary of the event. Any organized or serious attempt. Organized means they have planned it. It is not something which has happened spontaneously. For example, today after my school, I'll go back home. I'll make sure room is locked. I'll make sure I have my favorite chocolates. I'll have my favorite chocolates. Then I'll consume 100 paracetamol tablets and end my life. That isn't completely planned. One, I was watching TV. Suddenly, I felt like consuming tablets, paracetamol tablets, and I had tablets. That is something spontaneous. So if it is an organized and planned attempt or a serious attempt where it was having a life-threatening presentation, no social support. There is no one where this person can share his her feelings. There is no family members where he can share, no friends, or in job any colleagues he can share with, or any active religious affiliations he have where he can share his feelings. He clearly states that I have an intention for and future attempt for suicide, or you just discharge me, I'll go and consume again tablets. That is a clear future intention of self harm. Or you just discharge me, I'll go and stab myself. That is a clear intention of and self harm. Here, the priority is given for few things where you can see there are 2 points given. These are the 2 points, 2 points, 2 and 2. So clear intent gets 2 points. Organize a serious attempt gets 2 points. Loss of rational thinking gets 2 points. Anyone who is depressed or hopeless gets 2 points. Accordingly, you will score. Someone who has a score of intermediate or high, you admit them because they are at high risk of committing a suicide, or they are high risk of eliciting an injury which can be life-threatening or limb-threatening. So if you discharge this patient, next time you may not be able to save this patient. This patient next time might come as death or might come as a life-threatening injury. For that particular reason, you need to admit this. Anyone who has a score of 6 or more, they are at intermediate to high risk. Anyone who has a low risk, you can discharge according to the SAT person. But the NICE says that you cannot just do and scoring. Just doing and SAT person scoring, or for that matter, do and any other scoring and classify as high or low risk. No, that doesn't make sense. Because each patient, it differs. You need to take an bedside. You need to take an bedside call what next to be done. For example, immediate risk. He says that you discharge me, I'll go and suicide myself. I have already have a plan what needs to be done. I'll go to a hill station, I'll jump from a hill. So that is an already pre-planned. That is an high risk. That on a sad person score, it scores 2. Just everything might be negative. It becomes a low risk. No, you need to consider each patient separately. You cannot do just and scoring. That's what the NICE recommends. So if in your stem of the question, if they particularly ask for sad person score, then use it. If they do not ask particularly for a sad person score, then you need to take it case by case. Any past history of self-harm or suicide attempts are there. So again, she's repeating again and again then. Any mental health issues are there. For example, in depression, or mood is not right, or thought process is not right, or there are some drug addicts or alcoholic, chronic alcoholic. Any triggers are present. Triggers are so strong that it can lead to a life-threatening injury. Support. Anyone is there to support them. Any social issues at work or housing or money, any social issue it can be. Safety plan. Can we make a plan to keep them safe? Can you discharge them and you can have any adult to supervise them so that there is a safety plan in place? These are all you need to consider before you discharging a patient. Sometimes you might feel, no, there is no safety net. The kid is very young and there is a mother who has recently expired. So this kid can do anything. So in that per se, yes, you need to admit. So you need to consider each case by case and take a call on what needs to be done. We will be discussing in the questions to get and better clarity. Depression. Anyone comes and tells you in the emergency department, I am depressed. What you'll do? You'll just say that follow up with a GP. Nothing can be done in the emergency department. You cannot start on the antidepressant medications. You cannot start on an SSRIs. You cannot start on tricyclic antidepressants. So what you basically should be worried about, if they have a severe depression, when do we call it as a severe depression? Severe depression is any 5 of this which has been mentioned here which lasts for 2 weeks. Then you can consider it to be a severe depression. If they are severe depressed, they can cause self-harm to themselves. Then you will be enacting. If they just come with a depression, you will not be doing anything in the emergency department. You will be just referring them. What are this? This can be remembered with a mnemonic known as siege caps, where S stands for sleep. It can be no sleep or excessive sleep. Interest, I stands for, it can be reduced in the, he or she used to like to play football. No longer she likes to play football. Or he or she likes to play video games. No longer they like to play video games. Guilt. For every small thing, they are having a guilt. I killed an ant. I feel like killing myself. How can I kill an ant? That is an unrealistic guilt what the patient is having. Energy. I just do not have energy. I don't feel like getting out of my bed. So I skip my breakfast, lunch, and dinner. I'm just being on the bed. That is something very depressing. Concentration. Unable to concentrate on the regular activities. Any activities, they're just not able to concentrate. They're getting distracted with minute things. They cannot concentrate for the 5 minutes and do a job. Appetite. They might be binge eating, that is increased appetite, or they might not be having anything at all, that is decreased appetite. Psychomotor, that is agitation might be there, retardation might be present. Suicide thoughts, they might just have the thoughts of suicide, or they might have planned of in suicide, or they feel like, I feel like killing myself, but I do not want to kill myself. Any of this can be present. So any of the 5 symptoms lasting for 2 weeks, then you call it as a severe depression. Severe depression can lead to an self-harm like suicide and kill themselves. So we need to be careful with them. Again, we need to see case to case. Severe depression. Do I need to admit? Do I think this patient will be safe if I admit? Can I have a safety plan for this patient? You need to think in this manner before you discharge this patient. Next, very important topic is acute behavioral disturbance. Acute behavioral disturbance is an umbrella term. Okay, it is basically an umbrella term which is used to describe the presentation, how they present to the emergency department. You label this as an acute behavioral disturbance when you do not know the underlying cause. This acute behavioral disturbance can present like an agitation or bizarre behaviors where they are paranoid or hypervigilance or they're very fear and panic. They have a very high threshold of pain they might have having, and unusual and unexpected strength they might be having. They might be breathing heavily. They might be having high heart rate. So all these are kind of increased sympathomimetic activity presentation. To simply just remember as increased sympathomimetic activity. What we have already learned in the toxicology chapter is the same thing what I'm talking about here. They might be very much in euphoric state, or they might be very much panicky, paranoid, hypervigilance, and they might be agitated, pacing around the room and not being just still. They are fear, panicky, hot, increased core temperature, profusely sweating, tachycardic, tachypneic, high blood pressure. These are all can be the presentation of acute behavioral disturbance. Having said that, there might be one of this might be present, few of this might be absent. What are the underlying causes? There are plenty of underlying causes it can be. It can be because of a heat stroke. It can be because of a substance abuse like an sympathomimetic, like a cocaine. It might be because of an mental disorders like an schizophrenia, where they are having hallucinations, serotonin syndrome, any electrolyte imbalance, especially hyponatremia can cause this. Severe sepsis leading to delirious state can cause this. Any anticholinergic drugs can result in overdose of anticholinergic drugs, neuroleptic malignant syndrome, thyroid storm, seizures. There are plenty of causes. If you know the cause, then you're treating the cause particularly. For example, if you know this is because of an alcohol withdrawal, a substance withdrawal, then treat it accordingly what we have learned for that particular condition. We do not know the underlying cause. We do not know the underlying cause. That's when you label it as an acute behavioral disturbance. That's when you follow this algorithm what I put up in this slide. First of all, you need to question itself. Is it safe for me to go near that patient and talk to him? He's holding a knife and threatening to stab. Is it safe? No, it is unsafe. He's just spitting on you. He's urinating on you. Okay. And he just has a sharp object in his hand. Is it safe? Is it unsafe? He's just verbally abusing you. He's just not cooperative. No, don't check my vitals. No, how dare you touch me? That is fine. Okay. That is fine. That is safe. He's not threatening to harm you physically. I'm talking about he's not having any dangerous objects with him. He's not threatening to harm you in any manner. Then it becomes safe for you. If it is safe, then you can go and talk to him. You can do an verbal de-escalation. Talk to him. What is causing this? Are you hungry? Would you like to have a meal? Is anyone causing any harm? Is the light too bright? Is it too noisy here? Would you like to be in another cubicle where you feel comfortable? Is it too cold for you? You want me to increase the room temperature or decrease the room temperature? Would you like to have a tea, coffee, which will help you to ease it down? Or would you like to have an oral lorazepam? You will feel better. It does happen. An agitated person who is alcohol withdrawal, he will know, he'll say that give me diazepam 10 mg, it works beautifully for me. He'll know exactly what dose needs to be done. He will be having agitated, pacing around. He knows because he's withdrawing from the alcohol. These persons will come and seek, I want a diazepam. Can you please give me a diazepam? Yes, you can offer that point of time with a tighter dose. If it's an unsafe environment, in unsafe environment, most of the time we incline towards doing a rapid tranquilization because we want to evaluate and see what the hell is happening here. What might be the underlying cause? Is it a substance abuse? Is it a substance withdrawal what the patient is having? Or is it because of a severe infection and the patient is being delirious? Is it because of a head injury? Is it because of any intracranial mass which is causing the seizures? We do not know. So physical restraint is not preferred in that manner. Physical restraint is more done because you want something to be You're strongly thinking it is an hypoglycemia. You want to just check the blood sugar levels. Okay, but that also doesn't make sense, because if you want to correct the hypoglycemia, then you need to get an IV cannula and give the complete treatment. You cannot just do it within physical restraint, because the recommendation is keep it as minimum as possible. In the previous recommendation, they had recommended that keep it less than 10 minutes precisely, they had mentioned. So you cannot go more than 10 minutes. Now they do not want the time duration here. They want to say that physical restraint should be as minimal, like few seconds or 1 or 2 minutes. They do not want to have a strict timeline saying that 10 minutes, 9 minutes, 59 seconds, then you do an rapid tranquilization. You do not want in that manner. That's why they're removed. But grossly, you can remember it as more than 10 minutes. Physical restraint is not preferred at all. Rapid tranquilization. Rapid tranquilization is the way to go ahead. You might ask me to give an, for example, an IM ketamine. I need to restrain the patient. That is included in rapid tranquilization. That is not considered as a physical restraint separately. Rapid tranquilization, whether you want to hold the patient, that is physically restrain him before you give an IM ketamine or an IM lorazepam. Yes, that is a part of rapid tranquilization. What is the first choice of drug for a rapid tranquilization? Is always ketamine. If ketamine is not given in the choices, you can use dorperidol. Second choice of drug is midazolam, lorazepam, and haloperidol. Previously, the NICE guideline used to suggest an lorazepam, but RCAM has come up with its own guidelines for acute behavioral disturbance, ABD, short form, what they call it. So stick to RCAM guidelines. This is an RCM exam what you're having. NICE, they are not yet updated. Still, they stick to an lorazepam, and few of the old questions have the right answer as lorazepam. They're not even mentioned in the options as in ketamine. In elderly patient, torperidol is preferred. Ideally, which route is preferred? IV. Most of the time, IV may not be possible. If it is not NC2, then IM you can give it. Keep the antidote for that particular drug ready. Okay, for example, you are giving an benzodiazepines. So flumazenil, you can keep it ready in that manner, an antidote if available. Make sure you're doing rapid tranquilization in an cubicle where resuscitation equipments are available, including an difficult airway trolley. And you have adequate personals before you do an attempt. That is important. Consideration for anesthesia and intubation. Whenever you suspect there might be an airway compromise or there might be a threatened airway, if the patient is not maintaining enough oxygenation or there is retention of carbon dioxide is present, or you're given enough safe sedation doses, you're given maximum you're reaching, if I give more, there will be respiratory compromise, or there is a persistent metabolic derangement. This person is very hyperactive, having high core body temperature, then you might have to intubate in all these circumstances. It's easier to remember. It's nothing special indications what they are mentioned here. The important thing is what is the choice of drug? Choice of drug is ketamine. You do not want to use an suxamethonium. Suxamethonium, one of the side effects is it can cause hyperkalemia. These patients usually will be very much agitated with having increased motor activity that can cause rhabdomyolysis and increase in potassium levels. That's why it is not recommended to use suxamethonium. You can use an rocuronium or atracuronium as in skeletal muscle relaxant if you want to intubate the patient. Fentanyl. Fentanyl is a type of serotonin drug. So if you're suspecting a serotonin syndrome, avoid giving fentanyl. Morphine. Morphine can cause in a very high doses vasodilation and decrease the blood pressure. If the patient having a blood pressure on the lower side, then avoid giving morphine. Maintaining sedation in a non-critical environment without anesthetic support. You give an initial dose of ketamine IM. That's the drug of choice. But you want to maintain it. Okay, you want to maintain it for 5 hours, 6 hours, 7 hours. So you can use any of the drugs what has been mentioned here. Like you can use benzodiazepines like diazepam and lorazepam, or you can use antipsychotic drugs like an haloperidol or olanzapine, or chlorpromazine can be used in various drugs and various needs what has been mentioned here. What you need to take away from here is if you're strongly suspecting it is an alcohol or sedative drug withdrawal, benzodiazepines is preferred. Do not use antipsychotics in an Parkinson's or an QT prolongation if it is present, or it's a known case of QT prolongation, or the recent ECG shows QT prolongation, or if the patient is a known case of Parkinson's. Do not use antipsychotics because it also causes QT prolongation, can predispose to polymorphic ventricular tachycardia. For that reason, we are not using it. Is it absolutely necessary to remember the doses? No. Any special notes, anything specially here present? No, not really. In elderly patient, start slow. That means give low doses, titrate, and slowly it increases. Start slow, go slow. Do not give higher or maximum doses at the initial time because they might act differently. Their physiology might not be as good as an adult person or an young adult person. In pediatric, there are no special changes what have been recommended. This should be the tighter dose for that particular weight of that particular child. You need to calculate and give it. Anyone who has learning difficulties, involve the carer, the one who takes care of that particular person. They will be knowing exactly how to take care of the person, how to de-escalate. You may not require any drugs to be used. You may not require any rapid tranquilization in this patient. Just involve the carers. They might do an verbal de-escalation better job than you because they know this person in and out. So involve the carers. It will help you to communicate better with this, especially with verbal de-escalation. It will be excellent if the carers are present. The following symptoms make delirium, that is nothing but organic cause, more likely than a non-organic cause like an psychosis or dementia. What is dementia? Dementia is a chronic thing what you're talking about. It's a chronic disorder what you're having, where there might be fluctuation over days. Few days are good, few days are bad. How did the dementia start? Dementia started since last 3 years, 4 years. Slowly he had a memory loss. He cannot remember much here. Few days he has a good days where he remembers. Few days he has bad days where he doesn't remember. That is known as dementia. It is a chronic thing which is happening. Psychosis is a broad term. Psychosis can be because of schizophrenia. Psychosis can be because of bipolar disorders. It is a broad term what I'm using here. Psychosis, psychiatric disorder I'm talking about. What is the difference compared to that of the delirium? The patient is delirious or delirium. It's an organic cause. The patient is confused acutely. Okay, few minutes he might be oriented, few minutes he might be disoriented. He's basically confused. He's delirious, we call it. What might be the cause? It might be substance withdrawal, it might be substance intoxication, it might be severe infection, it might be a heat stroke, it might be neuroleptic malignant syndrome, it might be malignant hypothermia. There are various causes for that. But this is an organic cause. That means there is some underlying organic cause. It's not a psychiatric disorder or it's not a dementia. It's not a psychiatric basically issue. There is an underlying cause. For example, severe infection, treat the severe infection. So if the following symptoms are present, then you're thinking of an organic cause. There is some underlying thing is present. It can not be a psychiatric disorder. Things what you need to look out for is non-auditory hallucinations, dysarthria, ataxia, gait disturbances, incontinence, focal neurological signs. If any one of this following is present, think there is an organic cause. Focal neurological signs, it might be a stroke the patient is having. Frontal involvement, that's why he is having disinhibition. Gait disturbances or non-auditory hallucinations, commonly seen because of alcohol withdrawal. It can be delirium tremens what the patient is having, where you need to treat it with benzodiazepines. So it depends. If one of this is present, always think as an organic cause. Assessment of delirium. The patient is delirious. How do you know if the patient is delirious or not? By doing an 480. Okay, NICE recommends to do 480 in the emergency department. You can also do something known as CAM, confusion assessment method, simply known as CAM, but this is not preferred in the emergency department. It is more for the intensive care or post-op in the surgical units. It is done. For us in emergency department, it is a 480 what you need to be aware of. What is 480? 4A test. It is 4A stands for, one A stands for alertness, another A stands for AMT, another A stands for attention, another A stands for acute changes or fluctuating course. Alertness. Is he fully alert? Okay, get 0 point. He's mildly sleepy, but once you wake him up within 10 seconds, he's completely normal, back to himself, completely oriented, 0 points. Clearly abnormal, he's drowsy, he's agitated or hyperactive, he's not by himself. Then you directly get 4 points here. AMT. AMT, there are two kinds of AMT. AMT stands for abbreviated mental test. AMT 4 is there, AMT 10 is there. In 10, 10 things are tested. In 4, 4 things are tested. What are the 4 things which are tested? Age, date of birth, place, and current year. You basically testing for cognition. Is the cognition abnormal or is the cognition normal? What you're testing, each one carries 1 point. In abbreviated mental test 10, you're testing for age, time, current year, what it is, what's your home address. Can you identify 2 persons? For example, a relative might be there and a doctor or a nurse and a ward boy in that manner. Date of birth, year of First World War. When was the First World War? Who is the current president or monarch in UK? Can you count backwards from 20 to 1, 20, 19, 18, 17, 16 in that manner? Asked to recall addresses given earlier. That means the address, the home address, what they are given. Can you please recall the address and tell me what is it there? If the score is between 0 to 3, severe cognitive impairment, 4 to 6, moderate cognitive impairment, anything more than 6, then you're not suspecting in delirium or there's no cognitive impairment is present. That is AMT4, what is used here, not AMT10. But what was included in AMT4, what is not included in AMT10, that has been previously tested. So you need to be aware of both AMT4 as well as AMT10. Then attention. Attention is you'll ask them to say the months backwards. December, November, September, October, August, in that manner, July, June. If they can achieve 7 or more correctly, then gets a 0 point. Less than 7, they get 1. You're not able to test them because they're drowsy, they're refusing to do it, or they're inattentive, then you get them 2 point. Acute changes in the GCS, acute disorientation, or acute loss of cognition or mental state, alertness, all these 3, then it becomes 4. If those are intact, then it becomes 0. Anyone who scores 4 or more than 4, then this patient is delirious for sure. 1 to 3, possible delirium. 0, 100% they're not delirious. Eating disorders. There are various eating disorders like anorexia nervosa, which is commonly seen in young individuals, and the BMI will be very low in these individuals. Bulimia nervosa, usually the BMI will be in the normal range. This is seen somewhere in 20s to 30s, especially in the females. Binge eating, they eat a lot, as they say. Avoid restrictive food intake disorders. Some particular foods they do not want to eat. There's just basically an avoidant disorder what is present here. So we do not diagnose an anorexia nervosa or bulimia nervosa or an binge eating disorder in the emergency department. This patient present to the emergency department with a complication. So we need to go through a risk checklist. This risk checklist is known as MED score. MED is Medical Emergency Eating Disorder Risk Checklist. This is done for the eating disorders. Does the patient have an eating disorder already diagnosed with something like an anorexia nervosa or bulimia nervosa or binge eating disorder? Yes. Then you go to the second step. No, means first it requires a psychiatric evaluation. Let them diagnose it. You are not diagnosing this one of these psychiatric disorders of eating. If the patient is already diagnosed with anorexia nervosa, does this patient require an admission? Is this patient medically compromised? How do we know? By going through this checklist, what is present here, you need to be aware and you need to remember. So how did I classify this? I have classified or rearranged this. This may not be the situation in your blueprint. So I have rearranged it so that it is easy to remember. So this is what I'm talking about and history. So we can go in a manner. So then I have the vital parameters, vitals, what I call it. Then I have the UNE. Then I have the LFT, that is transaminase. Then lastly, I have the ECG. In this manner, you can easily remember what is the history. Does they have a suicidal thought or behaviors of a suicide? Acute food or food refusal, that is less than 400 kilocalories per day. That means less than 1 meal per day. You can remember 400 kilocalories approximately equals to 1 meal. Recent loss of more than 1 kg for 2 consecutive weeks. Or it can be an half a kg loss for 2 consecutive weeks or 2 kgs loss for a week. Any permutation combinations, loosely you can take it. BMI less than 13, heart rate less than 40, postural hypotension or the plate pressure is on the lower side, core body temperature is less than 35.5. These are all the vital parameters. In UNE, we check for the glucose, which is less than 3 millimoles, sodium less than 130, potassium less than 3. Easy to remember is 3. 3 millimoles for glucose and potassium, for sodium 130. 3, if you remember, it becomes easier. Increased urea and creatinine above the normal upper limit. Raised transaminase, that is basically the enzymes. We are talking about hepatic enzymes, ALT. Basically, we are talking about ALT and AST hepatic enzymes. Any abnormalities which is new for the patient in the ECG, what we are looking for. If yes, then what we need to do? We need to admit this patient and treat the patient for the underlying cause, what the electrolyte environment is, or the low glucose is present, we need to treat it. If no, then you need to see whether this patient is under section. Okay, this is known as Mental Health Act, which we'll be studying in the last chapter, SLO7. It requires a mental health assessment. Are they in the under section? If they are under the section, does the section allows you to treat against their consent? If yes, you can restrain the patient and treat it, or do a rapid tranquilization and treat the patient. Sometimes they might go ahead and give an consent, then you go ahead and treat the patient. Acute dystonic reaction. This is a reaction which is seen, or it is a side effect which is seen because of an antipsychotic medication or because of a consumption of an metoclopramide. They can have an grimaces, or they can have an facial masseter spasm. They might have a deviated nasal gaze, deviated gaze they might be having. Torticollis. Remember, torticollis is not a diagnosis. It's just a spasm of sternocleidomastoid muscle. There might be having oroingual dyskinesia, where there will be just protruding their tongue outside in an abnormal fashion, what you're seeing here in this picture. They might be having limb rigidity. Okay, these are all kind of episodic they'll be having. They present here, they had it, and sometimes you're observing and the patient is completely fine. It might feel like the patient is basically doing it voluntarily. It is malingering what the patient is doing, but it is not malingering. Okay, you need to take a thorough history. First, what you'll be doing, stop the offending drug and treat it with procyclidine 5 mg, which is available in the intravenous form. You can also give an benzatropine, but it is not available in the UK. You can also give an diazepam, but it is less effective and it can cause addiction. That's why the drug of choice remains a procyclidine. The side effect of procyclidine you need to be aware of, they might become euphoric. Once you give the procyclidine, the symptoms like drastically it disappears, but it can reoccur back. So when you're discharging them, make sure you prescribe them oral procyclidine 5 mg and prescribe them, because whenever the symptoms recurs back, they can take it at home itself, need not return back to the emergency department. Alcohol consumptions. 1 unit is equal to 10 ml of pure alcohol. It is equal to 25 ml of spirit. That is equal to half pint of beer. That is equal to a glass of wine. That is basically 125 ml. Just for your reference, when we say 1 unit, means how much it means. For males and females, maximum they can consume units per week is 14. For both, it is the same. Previously, it was different for males and females. Now, for both, for males as well as females, maximum is 14 units per week what they will be consuming. That is the maximum. When do we call it as a binge? If a female drinks more than 6 units or the male drinks more than 8 units, then we call it as a binge. How do you know the person is dependent on alcohol? You can do an KH questionnaire. You can do an Paddington's alcohol test, or you can do an audit C. The best one is audit C, which is recommended by the NICE. Audit C has 3 questions basically. Depending on that, their points 0, 1, 2, 3, 4 points are there. If someone scores a point equal to or more than 5, then alcoholic addict, he might be possible hazardous drinking, what we call it. What are the 3 questions? How often do you drink alcohol? If yes, how often do you drink alcohol? In a month or in a week, or every day you drink it? Okay, that is important. How many units of alcohol you drink in a typical day? When you drink, how many units do you drink? How many times do you drink more than 6 units? In a month, how many times do you drink? Or in a year, how many times? Or weekly do you, or daily you drink more than 6 units? That becomes, depending on that, you get a score. If the score is 5 or more, then it becomes an alcoholic addict, or you're suspecting an alcoholic addict. The legal limits of alcohol for drivers in the UK, it's just for your knowledge purpose what I put it across. Unlikely they test you on the numericals. Alcohol withdrawal. It is important to understand the alcohol withdrawal. What happens here? It is an imbalance between the GABA and an NMDA neurotransmitter. That's what happens in an alcoholic withdrawal. Because of this withdrawal, they can have various things. A very simple one is an alcohol withdrawal state, which is usually in 6 to 12 hours. This is nothing but hangover. Okay, you might have had a bit too much of alcohol, and next day morning you have an headache, nausea, tremors, insomnia, slight tachycardic. Okay, this is basically very much similar to the alcohol hangover, what you call it in a layman's term. Acute alcohol hallucinosis. As the name says, hallucinosis, this patient is having hallucinations, commonly seen between 12 to 24 hours. So it can be an auditory or visual hallucination. only hallucination they are having. Let me repeat. They are having only hallucination. They do not have any other symptoms. That means they are oriented to time, place, person. They are not delirious. They're not confused here. They're completely oriented. If it is an alcohol withdrawal state or an acute alcohol hallucinosis, we usually end up treating with benzodiazepines like diazepam or chlorodiazepine oxide can be given. Preferred most of the time is orally because they will be quite stable to take it orally and they will be quite cooperative to take it orally. Alcohol withdrawal seizures. This is commonly seen between 12 to 48 hours. They have in generalized tonic-clonic seizures. The special thing about these seizures is they'll not have any post-ictal confusion. This is very typical. They will not have a post-ictal confusion. So like any seizures, if it lasts for more than 5 minutes, we end up treating with an benzodiazepine. Preferred one will be IV lorazepam. Acute withdrawal seizures can end up into an delirium tremens. It is a true emergency. It can be life-threatening condition, commonly seen between 24 to 72 hours after stoppage of drinking. Life-threatening features like the patient will be disoriented, delirious, hallucinating. Autonomic signs will be on the higher side, that is high blood pressure, tachycardic, tachypneic, high core body temperature, profusely sweating these patients. Most of these patients will require high dependency unit care, and we will be giving intravenous benzodiazepines like lorazepam. How to differentiate between an acute alcoholic hallucinations and delirium tremens? As I told you, in delirium tremens, they will be hallucinating. In acute alcohol hallucinations, also they are hallucinating. But in delirium tremens, along with hallucinations, the patient will be confused, disoriented, delirious, tachycardic, that is high heart rate this patient will be having, tachypneic will be having, the patient core body temperature will be on the higher side. This is suggestive of delirium tremens. That's how you'll be differentiating between an acute alcohol hallucinosis to that of the delirium tremens. How much benzodiazepine needs to be given? A patient can't come and tell you, I'm withdrawing, give me 20 mg of diazepam. Will you give it in 20 mg of diazepam? It depends on a scoring. So you have an scoring, you can do an scoring. This scoring is known as Clinical Institute Withdrawal Assessment for Alcohol. It has 10 different components, that is nausea and vomiting, tremors, paroxysmal sweats, anxiety, agitation, auditory disturbances, visual disturbances, headache, disorientation. Depending on this, usually there will be a checklist. No one will remember this. Depending on the scoring will be there. So 0 to 9, you do not give any treatment. 9 to 19, 10 to 19, you consider giving benzodiazepines. More than 20, definitely you'll give benzodiazepines. So depending on the scoring, you decide how much to be given. The higher the score, higher the dose will be required. Lower the score, benzodiazepine might not be required at all. Okay, usually there will be a checklist. Most of the nurses will do it for you. Going through this checklist is an easy checklist, and they'll come and tell you the score. So depending on the score, remember the score. First 10, you're not doing anything. Next 10, you consider giving benzodiazepines. Next 10, you're definitely giving benzodiazepines. In that manner, I usually remember it will be helpful. Tested in OSCE exam, can be tested in an SBA exam also. When to admit a patient who is having an alcohol withdrawal? If they are having a risk of alcohol withdrawal seizures or delirium tremens is present, or the age is less than 16, or vulnerable people like they do not have any social support, or they have learning difficulty, or they have severe comorbidities, admit all those individuals. Opioid withdrawal. Opioid withdrawal, whenever someone is withdrawing from the opioid, suddenly he is an IV drug abuser or then heroin, suddenly stop taking it, cannot get an access to it. So they can start withdrawing. How much to give? They again, there is a scoring known as clinical opioid withdrawal scale. If I'm not wrong, anything score more than 8, I think you start giving this. First line of drug for here to give in opioid withdrawal is methadone. Second line of drug is dihydrocodeine. Somatic symptoms and related disorders. Somatic symptoms. Somatic symptoms and related disorders, this is a broad terminology. Okay. Before each one of this was separate. Now they are combined together and made it as an SSRD. In SSRD, we have a subtype known as somatic symptom disorder. Here, their complete energy is deviated towards and somatic bodily symptoms. That means bodily symptoms. I am having pain there, is very anxious about the pain what is having. So these pains will be at the various sites. They're always thinking about this one, and this is disrupting their daily activities. Illness, anxiety disorder, or hypochondriasis. They feel that they definitely has some serious medical illness. They feel that they're having an MI, though you have done an cardiac enzymes, ECG, you've gone ahead and got an angiography also done. But still they feel, I think, doctor, I'm having a myocardial infarction. You're missing it. Please look into it. So in spite of thorough medical evaluation, also these people think that they have a serious medical illness. Conversion disorder. It's also known as functional neurological symptom disorder. Here they are having a focal neurological deficit. For example, they'll be having a motor weakness, or they'll be having a sensory weakness, or loss of sensation might be present in this individual. Though you have done everything possible, medically cannot explain why this patient is having a loss of sensation in, for example, left middle finger, or he cannot sense anything in the left middle finger. You cannot explain it. You have done a nerve condition study, you have done an MRI scan, you just cannot explain it. For the focal neurological deficit, it might be a sensory or a motor. Then you call it as a conversion disorder. Factious disorder. Factious disorder means purposefully they are uh, purposefully they are faking the signs and symptoms. Okay. Here, when we call it as infectious, when there are not no external incentives are present, they're not seeking for anyone's sympathy, they're just doing it. Okay. Why they're doing it? There is no underlying cause. If they're doing it to get in sympathy, for example, or they're doing it to make someone feel bad about it, or to sue someone, that is known as malingering. If there is an external incentive is present, then it becomes a malingering. Last one is psychological factor affecting medical illness. Okay. You diagnosed with a pneumonia, prescribe antibiotics. The patient feels like, no way this antibiotic will be effective for me. I'll not take this antibiotic. Or that usually causes exaggerated or delayed recovery will happen because they just psychological factor that is, and I don't trust doctors at all. My wife has forced me, that's why I'm here. I do not trust the allopathic doctors at all. That psychological setup, if you have, it becomes difficult. There will be delay in recovery. It can worsen the condition what the patient is having. That is known as psychological factor affecting medical illness. Types of personality disorders. There are plenty of personality disorders in 2 slides what I have mentioned. What I want you to remember is what is mentioned in the board. For example, someone is paranoid. Paranoid means he's very suspicious. He feels that you're gonna kill him, though you're just a colleague. He feels that you're gonna poison him. So he just is suspicious and mistrustful he is. Schizoid. Schizoid means emotionally cold. He doesn't want any relationship. He's fine when someone is dead. He doesn't show any emotions at all. So emotionally cold he's. Schizotypical means it is a magical thinking what this patient is having. Eccentric thinking, magical thinking. I can fly, something like that. It's like unrealistic thinking he is having. Histrionic. Histrionic means must be center of attention. He goes to a party, everyone has to talk about him. He should be a center of attention. If he's not a center of attention, he starts being agitated. Antisocial. To be an antisocial, this is a normal terminology. You can take it as a layman terminology, also as an antisocial. The age should be more than 18, and he has difficulty to follow the social rules. He will be having few cases with the police because he has difficulty to follow the traffic rules also. He breaks the red light just like he wants to break it. So failure to conform to social rules or follow the social rules. Next one is borderline. Chronic feeling of emptiness and inappropriate anger. They feel something is wrong with me. For small little things, he gets angry and he bursts open. That is known as borderline personality disorder. Narcissistic, grandiose sense of self. He thinks he's superior to everyone else, though he may not be. He feels he's the special one. You can remember as Hitler, where he felt he's the one. Everyone are subordinate to him. He is the special person. That is known as narcissistic. Avoidant, unwilling to get involved with the people. He just doesn't like people at all. He's reluctant to go and talk to someone. It is, you can call it as an extreme version of an introvert. Dependent. He's still dependent. He's 20 years old, still dependent. He cannot take a normal decision. What to eat in the breakfast? Mother has to suggest what to rate. What to wear for his work? Wife has to suggest. So he's dependent on other adults, unable to assume the responsibility even for simple things, not a major decision we are talking about. Simple day-to-day daily activities he's not able to carry out. OCPD. Okay, OCPD is preoccupied with the details. Obsessive compulsive personality disorder is OCPD. Okay, they're preoccupied with details. That is different from an psychological disorder that is known as OCD, obsession compulsion disorder. They'll have an obsession. For example, they want to keep something very much clean. And that obsession should be in two different situations. For example, the obsession is at home as well as at the school. And they have compulsion for that obsession till they make sure that the table is clean. They cannot go out and do other activities. This obsession and compulsion is there at home as well as at school. If they are present in two different situations, then only you diagnose as an OCD. Again, you can forget about the OCD because it's a psychiatric disorder. We do not, as an emergency physicians, diagnose it in the emergency department. If you have any questions, please do mention in the chat box. Now we are entering into the environmental emergencies. These are also very important. Do not ignore psychiatric emergencies and environmental emergencies and go to the exams. Questions can have appeared and will appear in your exams. These are important topics. You cannot just, I do not like environmental emergencies, I'll just skip it. Do not do that. Hypothermia. Hypothermia is different from pyrexia. There is fever. Fever is not hypothermia. Okay, here there is a failure of thermoregulatory failure is present. That's why the core body temperature goes beyond your normal range. It might be because of various causes. Hypothermia might be because of various causes. Few causes we'll be learning today. It might be because of heat stroke. For example, it might be because of seizures. It might be malignant, neuroleptic malignant syndrome, malignant hypothermia. So broadly, we classify it as an exogenous heat exposure. Exogenous means external heat outside your body, like environmental conditions like high temperature and humidity. Endogenous, inside your body, might be because of in prolonged muscular activities, because you have taken sympathomimetics like an ecstasy, or marathon run or 10K you have run where you're not practiced at all. Or it might be in prolonged seizures the patient is having neuroleptic malignant syndrome or a malignant hypothermia. First, we'll be seeing a heat stroke. The milder versions of heat stroke is known as heat cramps, followed by heat exhaustion. Then you have an heat stroke. Heat cramps, core temperature. Core temperature between 37 to 39, then it is in heat cramps. Only cramps they are having it. Why do they have cramps? Usually because of exposure to the extreme heat, or it might be some heat which is not, the person is not used to it. They usually drink plenty of fluid. They get thirsty. They just drink plain water. They do not drink or take electrolytes. This causes dilutional hyponatremia. Because of dilutional hyponatremia, they get cramps. And oral rehydration fluid should be sufficient in these individuals. So most of the time, they do not present to the emergency department. They themselves know it, have an electrolyte, you will be fine. ORS is available on the counter. They take it. They do not come to the emergency department and wait for the hours for an heat cramp. Heat exhaustion. Heat exhaustion where the skin is moist and sweaty. So physiologically, they're trying to get the body's trying to get the body temperature down. There is enough fluid loss to have an orthostatic hypotension or postural hypotension. And there is a reflex tachycardia, what the patient is having. No CNS symptoms are seen in heat exhaustion. Core temperature usually is less than 40.6. To be more precise, 40.6. But clinically and grossly, we take it as less than 40. And these patients will require IV fluids. Contrasting to the heat stroke, the main thing which helps you to differentiate is the core body temperature being more than 40.6. CNS symptoms can be seen in both, but less prominently what you'll be seeing in heat exhaustion compared to the heat stroke. CNS symptoms will be more prominent in heat stroke. But early symptoms are very much similar to heat exhaustion. CNS symptoms may not be seen. So the main thing what differentiates from a heat stroke to a heat exhaustion is the core body temperature. If the core body temperature is more than 40, consider it as an heat stroke. Less than 40, consider it as an heat exhaustion. Eventually, multi-organ failure, DIC, renal failure, and coma can happen. Rapidly reduce the core body temperature here. The target is to reduce the core body temperature as soon and as fast as possible to 39 degrees Celsius. After this, active cooling, stop active cooling when the core body temperature is less than 39. Do not actively cool the patient. IV fluid should be given continuous. IV fluid should be very cautious, not continuous. We should be very cautious when you are giving it because they are prone for pulmonary edema and cerebral edema. There is no evidence of using any antipyretic medications like paracetamol or NSAIDs. What are the techniques to cool? Simple cooling techniques. If he's conscious, you can give a cool drink. Okay, reduce the room temperature. You can spraying some tepid water on the patients, placing eye packs where the cutaneous circulation is maximum, like in axilla, groin, and in the neck region. In a cooperative patient, you can immerse the whole patient in water, cold ice water. But this is most of the time it is impractical. It may not be available in the emergency department. The patient not be cooperative enough. That's why I'm written in cooperative. That means in a cooperative patient, you can do this. And especially stable patients, if they are connected to the cardiac monitor, along with the cardiac monitor, they cannot go in an ice bath in a tub full of ice, cannot go in. And another thing what they have mentioned here is it can cause a peripheral vasoconstriction and reduce the heat dissipation can happen. Okay, so it is an query thing. In few literature, it says it is the best method. In few literature says it is an impractical one. Do not use it. Most ALS and TINT says it is impractical. In cardiac arrest situations, infuse cold saline, cold fluid resuscitation you'll be doing. Intravascular cooling catheters can be done. Currently, physical methods of cooling are much more recommended. Neuroleptic malignant syndrome. It is an idiosyncratic drug reaction which happens to an antipsychotic medication. So someone who is on an antipsychotic medication, especially started recently, has an high core body temperature, then you think that it is a neuroleptic malignant syndrome. Classically, they present with a triad of hypothermia, muscle rigidity, and disturbed consciousness. Dyskinesia can be present, the blood pressure might be fluctuating, heart rate might be fluctuating in these individuals. As because there is increased muscular activity, you need to get an creatinine phosphokinase, CK, you need to get it done. They can have metabolic acidosis, so blood gas is important. DIC, it can trigger so coagulopathies. Rest of the, because underorgan injuries also can be seen in this individual, so you need to get all these vital parameters done. Electrolyte imbalance can cause ECG changes where you need to immediately restate the patient. So routinely we get anyone who has hypothermia, get all this investigation done. How do you treat this? If he's on antipsychotic drugs, immediately stop the antipsychotic. Do not give any further doses of antipsychotic. Mild to moderate, diazepam what you're giving. Okay, or lorazepam. Basically, benzodiazepines you're giving here in mild to moderate cases. Dentrolene is reserved for severe cases. Okay, only in severe cases, dentrolene is reserved. When do you use bromocriptine? You never use an bromocriptine. If you're using it, you need to call the National Poisoning Information Services, then only use it. So never bromocriptine will be the right answer. Benzodiazepine will be the drug of choice here in mild to moderate. If it is not working or if it is a severe presentation of a neuroleptic malignant syndrome, then you are using dentrolene. For hypothermia, what do you need to do? Nothing special here. It's the same thing what we have discussed: mist and fan technique, ice packing to the groin and axilla, external cooling devices, ice bath, and internal and invasive measures what you'll be using. It's the same thing which repeats everywhere. Serotonin syndrome. Serotonin syndrome is overdose of SSRI or combination of an SSRI with an MOA inhibitors or an tricyclic antidepressants. Okay, TCS, tricyclic antidepressants, basically. So might take minutes to hours after exposure, after taking an overdose to develop. So they have an altered mental status where the patient might be agitated, comatose, or seizures. Neuromuscular hyperactivity might be present, like myoclonus is important. Autonomic instability, similar to that of neuroleptic malignant syndrome. They might have tachycardia, bradycardia, hypothermia, hypertension. They might be fluctuating. Same investigations here also you are getting it done. There is an criteria to diagnose an serotonin syndrome. This is known as Hunter's serotonin toxicity criteria. Diagnosis: exposure to an serotogenic agent, that is an SSRI or MAO inhibitors or a TCA. Along with it, if the patient has a spontaneous clonus without you eliciting spontaneous clonus, or an inducible clonus plus or minus, plus agitated or is profusely sweating, or ocular clonus is agitated or profusely sweating, or tremors with hyperreflexia, or increased in muscle tone hypotonia with increase in core body temperature hypothermia, along with an ocular clonus or inducible clonus. So one of these criteria should be satisfied to diagnose according to Hunter serotonin toxicity criteria. This was tested in the FRCM last diet. So what do you do? First of all, avoid all serotonic agents. If there are SSRIs or MAO inhibitors, or even taking an fentanyl or an tramadol, they're all SSRIs. Stop them. Mild to moderate cases, benzodiazepine similar to a neuromuscular neuroleptic malignant syndrome, benzodiazepine. In severe cases, we end up using cyproheptadine or chlorpromazine. You need not remember the doses. If you're keen, you can remember. It's for your reference. Hypothermia is the same thing, nothing. Patient with persistent symptoms may require paralysis and ventilation. If I'm not wrong, it holds good here also in neuroleptic malignant syndrome. If persistent symptoms are there, in spite of using all these techniques, in spite of using diazepam and dantrolene in neuroleptic malignant syndrome, you'll be paralyzing the patient and ventilating the patient. That will be the best method to bring down the core body temperature. Same thing holds good here. Remember that you're not using dantrolene here. You're using cyproheptadine or chlorpromazine here for serious cases. Mild to moderate is same as neuroleptic malignant syndrome, that is benzodiazepine you're using. Hypothermia, it is same, no changes. So serotonin syndrome and neuroleptic malignant syndrome, it might have sounded very much similar. Autonomic instability, increased muscle tone. So how to differentiate if they're not given which drug they are on? If they're given on which drug, SSRIs, MOA inhibitors, or antipsychotic, it becomes easier. Antipsychotic, it becomes easier. Onset, again, usually they'll not mention the onset. Within 24 hours, it may take days to weeks. But neuroleptic malignant syndrome can develop in 24 hours. It will not be able to distinguish. To distinguish the features are the patient anyone having an myoclonus, or the patient is having a tremors, or the patient is having an ocular clonus, or the patient is having an hyperreflexia. Think of serotonin syndrome. The patient is having an bradyreflexia, reduced reflexes, or let pipe rigidity, or bradykinesia. That means difficulty in initiating the movement. That is known as bradykinesia. Think of neuroleptic malignant syndrome. Malignant hypothermia is rarely tested in the exams because it is usually encountered by the anesthetics while giving an general anesthesia. So it is an autosomal dominant condition related to a general anesthesia. So when do you give a general anesthesia? When you want to perform a procedure. So reflexes will completely lost. So this patient will be intubated when you are giving a general anesthesia. So intubated patient, what happens? They'll see that the end tidal carbon dioxide values are falling down or going high. Why? There is pressure over the ET tube. ET tube is getting kinked because the patient is biting on the ET tube because the masseter muscle spasm has happened. Okay, later on, they'll be having unexplained tachycardia, rise ETCO2, and tachypnea these patients will be having. Later on, they can develop rhabdomyolysis, tachyarrhythmias, and pyrexia. Pyrexia, more, it is an hypothermia what the patient will be having. All right. So stop the precipitating agent, complete suppurative management. Here, drug of choice becomes dantrolene. Rarely tested because it is seen because of a general anesthesia, general anesthetic drug. When you use it, you'll see. Remember that masseter muscle spasm, that is the bite on the ET tube, will be the first symptom. Later on, hypothermia, tachycardia, rhabdomyolysis, raised ETCO2, tachypnea, tachycardia can develop. Stop the precipitating, supportive management. Dantrolene is the management here or drug of choice here. Hypothermia. There is a Swiss state classification for hypothermia. Whenever the core body temperature is between 35 to 32 degrees Celsius, the patient will be having normal physiological response. That means he'll be shivering. To bring the shivering means shaking around, shivering, so that the core body temperature comes up, generating heat so that the core body temperature comes up. The consciousness level in this patient will remain normal. Between 32 to 28 degrees Celsius, the consciousness becomes impaired. They'll be not having any shivering. The physiological response is gone. Altered sensorium they'll be having. Here, in stage 3, they become unconscious. Vitals are present. They're still not in cardiac arrest, but they have become unconscious. They might become toast. The core body temperature usually will be between 28 to 24 degrees Celsius. No or minimal vital signs will be present whenever the core body temperature goes less than 24 degrees Celsius. That is nothing but the patient usually goes into a cardiac arrest if the patient core body temperature is less than 24 degrees Celsius. What is the aim here? Aim here is to gradually increase the core body temperature by 0.5 degrees Celsius per hour. In hypothermia, we drastically bring down the temperature to 39 degrees Celsius rapidly as soon as possible. In hypothermia, we are increasing. Rapidly, if you do it, these patients will have pulmonary or cerebral edema. For that reason, we shouldn't be doing rapidly. ECG monitoring is required. If hypotensive, give small boluses, do not give large boluses. What are the warming techniques you can use? It passive techniques and active techniques broadly we classify. Passive techniques like remove any wet clothes are present, dry the patient, cover with an blanket, warm room, increase the room temperature. Forced air warming like a bear hugger, which is very commonly available in NHS, they'll be using it. Google it, you'll come to know how a bear hugger appears. Active warming, humidified oxygen, warmed IV fluids. You can do an lavage, peritoneal bladder, pleural or gastric lavage. You can do it with warm fluids. Cardiopulmonary bypass in extreme situations where there is a cardiac arrest, then ECMO can be used. That is nothing but cardiopulmonary bypass. Frostbite. When because of the extremities and end vessels are present in your foot as well as in your hand, can result in frostbite when you're exposed to extreme colds. There are different classification. In first degree, what happens? There is only redness which is present. There are no blisters, redness, and some amount of edema will be present. In second degree, what happens is they start developing blisters. In third degree, what happens is this blisters will start having blood in him, that is hemorrhagic blisters. In fourth degree, you start having gangrenous changes, clear-cut gangrenous changes where deep tissue destruction is seen. How do you manage? Place the injured part in a warm fluid that is around 40 degrees till it turns pink in color. So this is nothing but reperfusion. It is happening. Severe vasoconstriction, it is dilating slowly. Reperfusion is happening. Reperfusion, usually it will be quite painful. So make sure the patient has good analgesic. And this will take around half an hour's time. Sometimes reperfusion injury can happen. Okay. When do you do an amputation? You might have seen in the movies, they cut off when they haven't forced bite. No, the recovery is good. When you dip it in a hot water, recovery is good. They can recover over days and months also. Do not just amputate immediately they come to the emergency department. Usually it is done after a month's time when there is a clear demarcated gangrenous mark is present. Then they amputate that part. Diving emergencies. Diving emergencies is an important topic you need to be aware of. What happens during diving? We'll be having a closer look here. So whenever you go below the sea level, so this much amount of water is above you. If you are here, this much amount of water is above you. So this much amount of pressure is there. So the increase in pressure, or when you're coming up, there will be drastically decreasing the pressure. Increase or decreasing in the pressure will result in barotrauma. So that is one mechanism. Because of that, you'll be having injuries. So what will happen? Descent barotrauma. That means increase in pressure. That is known as descent barotrauma. So air-filled spaces might get burst open. For example, ear can result in tinnitus, vertigo, deafness. Just decongestant analgesia should be sufficient. Can have perilymphatic fistula. At that point of time, ENT referral will be required. Can have an ruptured tympanic membrane, antibiotics you are giving. What is perilymphatic fistula? A fistula between the inner ear and the middle ear. This is known as perilymphatic fistula. Next one, they can have sinus. Okay, decongestant analgesia, that should be sufficient for sinus. Ascent, while you're coming up, then you can have pneumothorax, or you can have an mediastinal emphysema. They usually present with neck swelling, retrosternal chest pain, hoarseness of voice can be present. What is the other mechanism by which they can have any injuries? That is known as decompression illness. What is decompression illness? Decompression illness is whenever you go deeper into the sea, that is, you're going deeper and deeper into the sea, the pressure increases. If the pressure increases, the gas changes into an liquid. So maximum amount of air what we inhale has what? Nitrogen. This nitrogen is getting converted into a liquid. When you are ascending upwards, what will happen? When you're ascending upwards, this liquid will get converted into the gas. When it is getting converted into the gas, it forms bubbles. These bubbles can go and accumulate in any part of your body, can have any symptoms. Okay, dissolve nitrogen into the tissue and the blood, and it can have a stroke, it can have an MI, it can have a joint pain, it can have a spinal infarction, it can have a renal infarction. So it can present with any possible symptom. Okay, pulmonary barotrauma. Same thing, same logic here. Oxygen air. Here, what happens? The air bubbles released into the circulation itself, and it can cause an obstruction. It can cause an infarction, basically. So, what signs and symptoms they present with? They can present with joint pain, girdle pain, neurological symptoms, chest pain and breathlessness, rash, audiovestibular symptoms, not quite constitutional symptoms like myalgia. So they can present with any possible symptoms. In your stem of the question, they say he had recently gone for a deep sea diving. That is enough for you to consider it is because of a deep sea diving itself, unless and until proven otherwise. One thing I would like to mention it about the rash. This rash is associated with the itching, but this rash usually gets disappeared. Okay, this is known as cutis marmorata, and this rash disappears within 30 minutes usually and will not present to the emergency department with this rash because it takes at least 30 minutes to come to the emergency department. So what are what increases the risk for for the injuries in this patient, especially decompression illness? What are the risks? The deeper they go into the site, longer time they spend there, missed decompression spots. What they say is when you are ascending upwards, slowly you ascend this much, take a break. You ascend this much, you take a break. You ascend this much, take a break. If you do not take a break, you're missing one of this. Okay. Or multiple dives you're doing in a very frequent time. Elderly, yes, you're more prone. Your exercise during or after the dive, you immediately have taken a flight after this or gone and started with climbing a hill, or you basically ascended the altitude. Obesity where fat content is high, a person is dehydrated, or alcohol use prior to diving. Okay, 90% of these cases will present within 6 hours of the time, can present with any possible symptom as previously mentioned. How's the management? It's completely in clinical diagnosis. You cannot have any investigation done to label the diagnosis. Like any other emergency, you start with ABCD and blindly start them on high flow oxygen, regardless the saturation. Later on, you can titrate. So blindly start them. Every patient get an X-ray done if they have any chest symptoms to rule out a pneumothorax. IV fluids might be required. The key thing is this: people forget about this. Do not use Entonox or do not use any painkillers. Okay. If you're planning to use painkillers, it is advised that you discuss with the diving doctor before you use it because it can mask the recompression response. If intubation is required in these patients, intubation is required, then ET tube has a cuff. At the end, the ET tube has a cuff. Inflate this cuff with a sterile water. Do not use the water. Do not use the air. If air is used, the air-filled cuff, it can get deflated when you're doing a recompression therapy. Recompression therapy is nothing but hyperbaric oxygen when you're giving in under the chamber. When you give it under some pressure, you give it, then it is known as recompression therapy. Okay, this is how the recompression therapy is given. So another takeaway message here: step 1 is to give high flow oxygen. Definitive management is recompression therapy. Okay, this is the definitive management is recompression therapy. Step 1 is to give high flow oxygen. Do not give any painkillers without talking to the diving specialist. Drowning. Two things you need to be aware of: what is submersion, what is immersion. This is immersion where the face is above the water level. If the face is inside the water, then it is known as submersion. Okay, drowning, death by suffocation can be there, or near drowning survivals, at least they're survived for a little bit time. It doesn't matter what it is. There are two kinds of drowning. Okay, wet drowning and dry drowning. So your body has a mechanism: when you are dipped into the water, your larynx goes into severe spasm and will hamper your breathing, can go into hypoxia. Or sometimes the laryngospasm cannot happen, then you aspirate. When you aspirate, it causes pulmonary vasoconstriction and destruction of surfactant, which causes collapsing of the alveoli, again resulting in hypoxia. The ultimate pathophysiology, what is happening is hypoxia here. So what do you need to remember? Hypoxia is the main cause of death or morbidity and mortality in the individuals with drowning. So you are concentrating on the hypoxia. Investigations: ABG, chest X-ray, because you're aspirating. ECG will be required. Core body temperature, hypothermia can happen in these patients. Check electrolytes and blood sugar levels. So when you're lifting this patient out of the water body, lift the patient in an horizontal position. So in the horizontal position, you're lifting them. Do not lift it in an vertical position. You do not want to lift it up in a vertical position because there can be venous pulling of the blood can happen and the patient can go into cardiac arrest. Completely collapse can happen. If the patient is in cardiac arrest, the change to the standard ALS algorithm is to give 5 inflation breaths as soon as possible and do an early intubation, because hypoxia is the main cause for these patients for an cardiac arrest or morbidity and mortality, basically, to talk about. If the patient is asymptomatic, doesn't have any respiratory compromise suggested by a chest X-ray and ABG. So minimum investigation, what you need to get it done in a drowning patient, if they're asymptomatic, is chest X-ray and ABG. And observe for at least 4 to 6 hours. If the chest X-ray and ABG is fine, observe for 4 to 6 hours before you discharge them. If they're symptomatic, every patient needs to be admitted. What are the good and bad prognosis? Good prognosis and bad prognosis. Bad prognosis, if the immersion is more than 5 minutes, less than 5 minutes, it's a good prognosis. Extremes of the age will have bad prognosis. Older, someone in between the age, like 20s and 30s, they have good prognosis. Severe acidosis, bad prognosis. Coma on admission, bad prognosis. Someone has a good GCS at admission, good prognosis. Hypothermia is protective here, so good prognosis. Those who receive rapid on-scene BLS and respond to the initial measures excellently has good prognosis. High altitudes. Hypoxia caused by reduced atmospheric pressures at high altitudes. What happens? At high altitude you go, the inspired oxygen remains, the concentration remains the same, but the partial pressure of the oxygen will be on the lower side. Despite what you are inhaling, the fraction of inspired oxygen will remain the same. That causes hypoxia. This can lead to an acute mountain sickness, high altitude pulmonary edema, high altitude cerebral edema. These patients usually physiologically, to compensate, they start hyperventilating because they're hypoxic, they hyperventilate. End organs are not getting enough oxygen. That's why heart rate will increase to have a good cardiac output. If you stay for a longer time, erythropoietin will increase so that the oxygen carrying vehicles are RBCs. So the RBCs increase. Synthesis of RBCs increases. So the hematocrit value will go high. Because they are hyperventilating, these patients initially will have respiratory alkalosis. What is the best way? Tell them to come down, the altitude, descend down, give oxygen supplements. If you want to treat an acute mountain sicknesses, carbonic anhydrase inhibitors like acetazolamide can be used medications, but the best one is descent. Electrical injuries, whenever there is a shock, there will be entry as well as the exit wound will be present in these individuals. Electricity can be of an alternating current. This is known as alternating current, or can be a direct current. If it is an alternating current and they go into cardiac arrest, most likely it is because of VT or VF. If it is a direct current and they go into the cardiac arrest, most likely it is because of asystole. Rhabdomyolysis can happen. The electricity can break down the muscle fibers. That's why this investigations, including the electrolytes, you need to get it done, because in rhabdomyolysis we suspect an hyperkalemia also, and same thing what we learned in the nephrology chapter follow for rhabdomyolysis. These patients, whenever they have a burn to the head, refer them to the ophthalmology, because even after few days they can develop cataract and glaucoma, if not months. That's why ask them to follow up with the ophthalmologist if they have electrical burns on the head. If they present with any neurological symptoms, for example, seizures or headache or reduced GCS, always get NCT brain done. Someone who is asymptomatic, has a normal ECG, no significant cardiac history, and low voltage, then you can discharge. All this needs to be satisfied. Why ECG is important? The electrical activity can interfere with the cardiac electrical activity and they can have arrhythmias. That's why. If any ECG abnormality is present, you need to admit those patients. So no significant cardiac history, low voltage means 1000 volts, less than 1000 volts is a low voltage. Electrocution in pregnancy, you need to be extra careful. You need to always check for the viability of the fetus, check well-being of the fetus. Okay, why? Because it can cause spontaneous abortions, because amniotic fluid is a good conductor of electricity. Doesn't matter if the entry and exit wound is only in the hand, still take the obstetric advice or just evaluate for the fetus whether it is fine or not. When to admit the patients? Whenever ECG abnormalities or chest pain is present, any vascular injuries, at any point of time, if there is a loss of consciousness, rhabdomyolysis suggestive of an presence of myoglobinuria on urine routine, significant burns, high voltage injury, including lightning, admit those. High voltage injury, asymptomatic, still admit those individuals. Radiation incident. Whenever you come across a radiation incident, first thing what you need to differentiate is it an external irradiation or is it an contamination with the radioactive material? What do I mean by this? This is a person what we consider Sorry. Okay, consider this as an individual here. He's exposed to radiation. Okay, some radiations he got exposed to it. So some radiation he got exposed to it. So once he comes out of this situation, okay, once he comes out of this situation, he'll be no longer be exposed to the radiation. At the same point of time, he'll not be a source of radioactive material and he'll not be causing contamination to other people who are surrounding to him, because this is an external irradiation what has happened. Contrary to this or change to this, if the person has swallowed something or person has got exposed to something for a liquid which got poured over his limbs or over his body, then what will happen? This is a contamination with the radioactive material. He might have ingested that, or he might have swallowed that, or he might have got his skin might have got exposed to it. That is known as contamination. That is known as contamination with radioactive material. You need to differentiate this bit. Okay, if it is an external irradiation of the person, then you are not at risk of getting exposed. If you're not, you are at risk of getting exposed. Irritated patients usually develops an radiation sickness like myalgia, nausea, vomiting. This usually develops after few hours. What you do in the emergency department, you involve the ED consultant and you also involve the radiation physician. Okay, radiation physicist will tell you what needs to be done. So what you do in the emergency department, first step is wear PPE. Do not involve anyone pregnant or anyone is suspected to be pregnant or potential to be pregnant. Wear PPE, personal equipment, personal protective equipments are important. It holds goods. It's like a thumb rule for you. In BLS also, you see for the scene safety before you go and save the person. So your safety is first, then you will treat the patient. If you do not take care of yourself, then you will not be able to treat the patient. So always logically use or pick up personal protective equipments as first. What we discussed in infectious chapters also, what we discussed in the resuscitation chapter also, what I'm discussing here in this environmental emergency about radiation also. Personal protective equipments is important. Then what you do? You do a wet decontamination. For wet decontamination, you remove all the clothes, plastic bag it, use soap and water and scrub it nicely. Okay. In between, at any point of time, the patient has life-threatening disorders, ABCD assessment you'll be doing. So the takeaway message here is personal protective equipment, wet decontamination, involve the radiation physicist, he'll guide you what needs to be done. Your management in the emergency department is wet decontamination and supportive management. For your safety, first step always is personal protective equipment. Now we are going into the previous year questions. Let me see if anything. How we spot the difference between an avoidant and a schizoid in question, as they both avoid people and relationships? No, they don't both avoid people and relationships. Let me go back. They are emotionally cold. Okay, emotionally cold is someone is dead. I do not care. Your friend is dead. I do not care. Your parents are dead. I do not care. There is no emotions given. That is schizoid what you are having. Avoidant is they do not like to mingle with anyone. It's an extreme state of an or extreme end of a person who is having introvert personality. So we'll be discussing the questions here now. Just 1 second. We'll continue now with the discussion. A middle-aged male slipped and fell down into the water drain, submerged in the drain for approximately 10 minutes. Known case of hypertension and IHD. Which one of the following is a poor prognostic factor? Poor prognostic factor is the duration here, which is more than 5 minutes duration. Sex, comorbidities, tachycardia, high blood pressure, or not fair. Poor prognostic factor, immersion for more than 5 minutes, extremes of the age. Here it is a middle-aged person. pH showing severe acidosis, comatose at the admission or at the presentation. 32 years old, was recently diagnosed with schizophrenia, was started on the treatment by his GP. Complaints of profuse sweating and agitation. So he's having profuse sweating and agitation. On examination, he has a GCS of 13 to 14 and increased muscle tone. Heart rate, tachycardic, tachypneic, core body temperature. What is the diagnosis? Schizophrenia. Okay, so antipsychotic medications he is on. Along with this patient is having hypothermia. So we have hypothermia, tachycardia, and tachypnea. So all this goes in favor of a neuroleptic malignant syndrome. Straightforward question. There shouldn't be any confusion here. 37 years old female present to the ED department with complaints of a tongue protruding involuntarily out. Recently diagnosed with schizophrenia by her GP, who started on antipsychotic medications. The most appropriate medication for her complaint is tongue involuntarily coming out is known as orolingual dyskinesia. It is a side effect seen of an antipsychotic medication which is called as an acute dystonia. The treatment for acute dystonia is to give procyclidine 5 mg IV. So the drug of choice is procyclidine here. Do not choose diazepam. Do not choose benztropine. Procyclidine is the best. If you have to, for procyclidine is not given, then choose benztropine. If benztropine is also not given, then choose diazepams. A young patient present to the ED department, complaints of palpitation, agitation, confusion, sweating, and shivering. Okay. There is nothing else given. Dentist has prescribed tramadol for the pain management. Okay. The patient is on citalopram. What is the next step here asking? So what are we suspecting? Tramadol and an SSRI. Both of the drugs combined together can cause serotonin syndrome, and the features are suggestive of an serotonin syndrome. The core body temperature is 41 degrees Celsius. So is it a severe, mild, or moderate? It's a severe, I'm saying, because the core body temperature is quite significantly on the higher side. That's why I'm jumping to use either cyproheptadine or chlorpromazine. Here in the options, they are given and cyproheptadine. So cyproheptadine becomes the right answer. Dentrolin, we're not using here. He was trying to fix the electrical switch of a television, resulting in an electrical shock, sustained a small wound to the hand. Vital parameters are with the normal limits. Without the following investigations is a must before you plan to discharge. In any electrical injury, getting an ECG is a must. Any pregnant woman, making sure the fetal state is a must before you discharge. So here, you need to get an ECG done because electrical activity can interfere with your cardiac electrical activities. Known case of borderline personality disorder. Which one of the following is the correct regarding the borderline personality disorder? They are asking. Unwilling to get involved with the people. Okay, unwilling to get involved with the people, or being basically that it is basically suggestive of an avoidant. They're unwilling to involve with the other people. Grander sense of self. This is a narcissistic behavior what the patient is having. Sensitive and behavioral changes. This is borderline personality disorder. So here they are asking borderline personality disorder. This becomes magical thinking is schizotypical. This patient is having schizotypical. Unable to assume responsibilities. Dependent. He's dependent on others. A 40 years old, not allowing the nursing staff to check his vital parameters or secure the IV line. He is verbally abusing and physically assaulting the staff. Next step. Is it safe environment? This is an ABD presentation for us. Because aggressive, we do not know the underlying cause. That's why ABD presentation. In ABD presentation, safe or unsafe becomes important. Always ask yourself, is it safe or unsafe? I say it is unsafe because the patient is physically assaulting here. So I want to do a rapid tranquilization for this patient. Here, ketamine is not given. Whenever ketamine is not given, pick up lorazepam because it's an old diet question here. So lorazepam, what you are picking it up. Physical stress strain will never be the right answer here. An antisocial woman, because of violence against people in the antisocial woman brought by police to the emergency department because of violence against the people in the street. She's not cooperative, spitting on the hospital staff, most appropriate step. Again, not cooperative doesn't matter, but spitting on the hospital staff is a physical assault. What do you need to consider? She might be HIV positive. You cannot take this risk. So what is most appropriate? Doing rapid tranquilization. Ketamine not given. So I'm picking lorazepam as the option here. A 70 years old, recently he has been aggressive towards the staff and agitated. Known drug abusers and alcoholic addict. Unable to check the vital parameters as the patient is not cooperative. What is the diagnosis they are asking? The presentation is ABD. Can this be because of an cocaine abuse or heroin abuse, or can be this because of an alcohol withdrawal? Can be. We don't know the underlying cause still, as we do not know the underlying cause for the presentation of the aggressiveness here. That's why we are labeling this patient as an acute behavioral disturbance. What is not included in the sad person? Crohn's disease. Chronic diseases in certain literature says it is there. In certain literature says chronic disorders are not there. But what I recommend is pick up Crohn's disease here. Sex, no social support, previous suicide attempts, and depressions are definitely there in the sad persons. That's why pick up Crohn's disease. So this is the sad person, which we already dealt with. A young female present to the ED with complaints of generalized fatigue and dizziness. History of separation from her husband 3 months ago. Her vital parameters are within normal limits. According to the sad person score, what is the cause of her symptoms? This is because they're asking, according to the sad person, they are asking. Okay. Or what are the given options? What is included in the sad person? Separation and divorce is included in the sad person. If you go back here, separation and divorce is included here. Separation and divorce is included here. What about depression? Depression also included, but this can be an normal response to the husband who has expired. So we do not know. Okay, for that particular reason, we are picking up separation and divorce, which is clearly mentioned here. Separation and divorce here. Separation and divorce as one of the causes. Depression is also mentioned. I do agree. But in the stem of the question, it doesn't clearly say the patient has gone into the depression because it's been 3 months. There should be other symptoms of severe depression like loss of libido, appetite, concentration. All those symptoms have not been mentioned. To pick up separation divorce is clearly mentioned. Elderly female brought to the ED department. Carers complained that she has been confused, agitated, aggressive towards the staff since morning. So it is an ABD presentation. Patient is verbally abusing the nursing staff. She has an abnormal gait, verbally abusing. What is the most likely cause for her condition? Because she has an abnormal gait, this patient cannot have a non-organic cause like psychosis or dementia. This patient should be delirious. So organic cause you are suspecting. Which one of the following is an organic cause? Intoxication is an organic cause. A 33 years old male present to the ED department with complaints of headache, vertigo, severe pain in the muscles and joints, history of travel to Maldives for deep sea diving. He took a flight back to the UK. What is the initial step? So what has happened? He did a deep sea diving and climb up the high altitude by taking a flight, with all predisposes to having a decompression illness. Initial step is to start high flow oxygen. Referred to recompression therapy is the definitive management. Okay, definitive management. Suspected decompression illness in an individual. Which of the following patients is least likely to have the symptoms they are asking about? Joint pains, headache, weakness in the arms, dizziness. Yes, itching and the rash, least likely to present it with. That's why I'm picking up itching here. A 17 years old female has presented with a frightening sensation that her tongue is protruding involuntarily. She's 26 weeks pregnant on regular metoclopramide, which has significantly reduced her nausea and vomiting. Most appropriate medication. So metoclopramide has caused acute dystonia. That's why the symptoms are present. So what do you need to do? You need to stop the metoclopramide. And how do you treat it? By giving procyclidine in this patient. Is it safe to give it in pregnancy? Yes, you can give in pregnancy. Also, it is safe to give it in pregnancy. 87 years old has brought to the emergency department from Enkeros his known case of Alzheimer's, concerned that he is ill, aggressive, verbally abusing the staff, difficult to manage as he doesn't cooperate. What is the initial management here? So now it is an ABD presentation. The question is whether it is a safe environment or it is an unsafe. He's just verbally abusing, so it becomes a safe. Safe, we do an verbal de-escalation here. Check for the vital parameters. Okay, you might get a clue for the underlying cause and you can treat the underlying cause and look out for the underlying cause, and you can offer some oral benzodiazepines in these patients if required. So what are the vital parameters here we are checking for? Check for the oxygen saturations in these patients. It might be hypoxic encephalopathy the patient is having. So it is one of the vital parameters. Check for the GRPS. It might be hypoglycemia which is causing the symptoms in this individual. The ABD presentation might be because of hypoglycemia. Treat it accordingly because it is manageable. It is a safe. If it was an unsafe situation, then I would have picked up an intravenous lorazepam in this patient. Agitated, aggressive towards staff. He is a known alcoholic. His last drink was 2 to 3 days back. BM is slightly on the lower side. Next step here asking. So why do you think this patient? Two reasons. Might be because of hypoglycemia, because it is slightly on the lower side, or might be because of alcohol withdrawal. So what did I say in the endocrinology chapter? Whenever the hypoglycemia is mildly on the low, I said look for any other cause. If it is not there, then only picking hypoglycemia. Here it is there. Another cause of alcohol withdrawal is there. Alcohol withdrawal we are thinking. That's why I'm treating with an benzodiazepine like a diazepam orally can be given. A middle-aged male found wandering in the streets and swearing at the public. Verbal de-escalation, which was not effective. He's threatening to physically harm your staff. Most appropriate next step. Haloperidol, yes, can be given, but not first line of drug. Sedation till you reach the appropriate level, yes, sounds good here. Restrain him in the prone position for 20 minutes, absolutely no, not in, especially in the prone position. Request senior doctor in the shift for verbal de-escalation. They are already cleanly mentioned it is not effective. And he's threatening to physically harm. Doing this will be risking your own staff. Lock him in a room till he calms down. Uh, this is this shouldn't be done at any cost. Okay, that is being inhuman. Best thing is sedate till you achieve the appropriate level. If required, you might have to intubate the patient also. Drug of choice is always ketamine. Middle age, found outside the pub, disoriented. His GCS is in the ED is 12 to 13. What is the most appropriate initial step? So he's disoriented. Nowhere it mentions that physical abuse, nothing is present. For that particular reason, is a safe environment for us. In a safe environment, what do? We verbal escalate and check the vital parameters, including the glucose levels. The patient might be hypoxic because found outside the pub, alcohol consumption will what happen? It will increase the level of NAD and NADH. This will cause what? This will cause hypoglycemia. This hypoglycemia can present in this manner as disorientation. Alcohol breath test. How alcohol breath test if the patient is disoriented? Alcohol breath test, the patient should be cooperative to test it. So he has to take a deep breath and blow it in it. A worried mom gets a 15 years old female to the ED department with complaints of low mood, denies any suicidal ideation. Important point. She says it all started when she scored low in the exams and all her friends got good marks. She's currently planning to join the college. Next step. Is it a normal response? Yes, it is a normal response. Whenever, even if I get a low score, yes, I'll be sad. Especially when my friends have scored good, I am getting low marks, I'll be sad. It's a normal response. Discharge her with the self-care advice that should be sufficient. Do not run SSRIs or CAM. All those things will be a overkill here. Which of the following is included in AMT4? They are asking here. So the AMT4 includes age, date of birth, place, and year. Those are the things which are included. So which of the following is included? Date of birth is there. So these are the four parameters: age, date of birth, place, and year. Current year. Which of the following is suggestive of somatic symptoms? Somatic symptoms means pain at different sites. Okay, pain at least 4 different sites, 2 GI symptoms, 1 sexual symptom. It's all is suggestive of somatic symptoms. They are extremely focused on physical symptoms. Those are known as somatic symptoms. Non-alcoholic, purple color visual hallucinations with agitation, not consumed alcohol since 2 to 3 days. He's tachycardic, tachypneic, high blood pressure, core body temperature is increased. What is the diagnosis? Because he is having hallucinations and the vital parameters are abnormal, it is in delirium tremens. When we call it as an alcohol withdrawal hallucinosis, if all these vital parameters are stable, including the core body temperature, only having an visual hallucinations, then we call it as an alcohol hallucinosis, where the patient will not be confused. He will be oriented. Cognition will be intact. A pregnant lady, electrical shock, the patient doesn't have any symptoms, best management plan. We need to get ECG as well as obstetric assessment done in this situation. Agitated, aggressive towards staff and a known alcoholic. Agitated, aggressive towards staff and a known alcoholic. What are we suspecting here? We are suspecting an alcohol withdrawal here. So for that particular reason, what will be the drug of choice? Lorazepam perorally. The BM is fine. It is not because of hypoglycemia. That's why we are not inclining towards giving dextrose. Does this patient require thiamine? Yes, we give any patient who is a known case of alcohol thiamine, but not acutely. We can give it later on. Also, it's not the next best step or an important step. As a second step, yes, we can give it thiamine. A 30 years old male was brought to the ED department by the police. He's agitated and aggressive towards the turf. He's a known alcoholic. His last drink was 2 to 3 days back. BM is slightly on the lower side. What is the next best step they are asking? Again, it is the same thing what we had discussed previously. Hypoglycemia versus an ABT because of alcohol withdrawal. More sounds like an alcohol withdrawal here. That's why we are giving an lorazepam as the treatment here. You can consider ABT. Why are you thinking as an ABT? Because this patient has a known alcoholic. That's why we are suspecting. Because we know the underlying cause here. If you do not know the underlying cause, are you confused between it is because of an illicit drug or because of an alcoholic? That's why we do not choose. A marathon runner has collapsed while running, has a tachycardia, tachypnea, core body temperature increase. So I'm thinking of an heat stroke. So what do you do? Ice water immersion is not very practical. Increase the room temperature, no. Decrease the room temperature. Large fluid boluses are absolutely no. Admit to the ITU, yes, but it is not the next step. Rapidly reduce the core body temperature to 39 degrees Celsius, absolutely yes in this condition. You suspect in serotonin syndrome. Which of the following is most specific for serotonin syndrome? Most specific they are asking for. Ocular clonus or myoclonus. Those are more specific for an serotonin syndrome. Cogwheel rigidity is more commonly seen in an neuroleptic malignant syndrome. This can be because of multiple reasons. What we are having, core body temperature increase, it can be heat stroke, it can be neuroleptic malignant syndrome, it can be an malignant hypothermia. A middle-aged male slipped and fell into a water drain. He was submerged in the drain water for approximately 10 minutes. Good prognostic factor they are asking. So these are all good prognostic factor. Out of this, option number 5 is given, that is rapid response to on-scene basic life support. The patient has responded very well for the basic life support. A 25 years old female brought to the ED with a history of consumption of alcohol. Blood pressure is slightly on the lower side. Saturation is also slightly on the lower side. GCS is lower. Pupils are 3 mm bilaterally. Which one of the following is most appropriate? They're asking. Consumption of benzodiazepine with alcohol, give flumazenil. Benzodiazepines, if you consume, they cause respiratory depression. So unlikely here. Is it patient is having respiratory rate of 22. So unlikely. Consumption of opiates with alcohol, the pupil size is fine. So unlikely. Give fomepizole. We are not sure what kind of alcohol the patient is taken. So to give and fomepizole, we are not sure. They are gone to pub. They are said they not have told that some homemade alcohol. Then I would have thought of giving fomepizole. Give diazepam. The patient doesn't say that it is agitated or anything. The patient is unstable here, especially hypotensive. So we are choosing normal saline as the right answer. In this option, they would have given oxygen supplement. I would have chosen that because we always treat the patient as A, B, C, D, E. In the airway and breathing, I would have given him oxygen supplement. Then I would have given him the IV fluids. Okay, then I would have got the multiple drugs done here. Remember that alcohol withdrawal patient will be agitated, will be not be hypertensive. Okay, the core body temperature will increase because of the agitation. Patient will not be hypertensive. To give diazepam for this patient. Hypertension patient, so we are giving normal saline. Which of the following will help you with the assessment of the confusion? Confusion means delirious patient. AMT score, AMT 10 or 4, you can use it. Ideally, 480 should be used in the emergency department. A 15 years old female was brought by her parents to the ED department with complaints of visual hallucinations, being dull and not mingling with the people. History of menorrhagia is present, tachycardia is there, slight amount of tachypnea, borderline blood pressure, most likely cause for her symptoms. It is most likely an anemia. Rarely an anemia can cause an hallucinations. Okay. Menorrhagia, history of menorrhagia, increased blood loss, during her cycles has resulted in anemia. Anemia can cause the symptoms what has been presented here. Eating disorders doesn't basically very frequently cause an visual hallucinations, but can cause because of an electrolyte abnormalities. But how frequently does it cause menorrhagia? Very, very, very rarely. That's why we are picking anemia over an eating disorder. Multiple episodes of neck spasms. Recently diagnosed with schizophrenia, was started on a treatment with by his psychiatrist. He is completely stable without any focal neurological deficit. After 30 minutes, the nurse informs you that the patient has a neck spasm. Classical history of acute dystonia. This is so right away. The answer is acute dystonia. 70 years old, complains of pain in the right lower limb. Distal femur fracture is present. Agitated, aggressive. Which of the following is the next best step? Why this the patient is having agitation? That is the ABD presentation the patient is having. This patient is having an ABD presentation because of pain. So pain control, we need to do it. Distal femur fracture. Best pain control would have been to give an femoral nerve block. Because the patient is agitated while giving femoral nerve block, you can hurt yourself. In the meanwhile, what you can do, you can give an ketamine, which has an analgesic effect also. Lorazepam doesn't have, haloperidol doesn't have the analgesic effect. So doing an femoral nerve block, yes, will be the next. After giving ketamine will be the another step. A 35 years old patient came to the ED department with sweating, tremors, and agitation. Alcohol dependent, and his last drink was 36 hours ago. All glucose levels is slightly on the lower side. He's getting more agitated. Best initial step is to give an benzodiazepines. Can be given in any route. Diazepam will be the best choice for this patient. Known ADHD. Neighbors report her irrational behavior, including fighting with their dog. The most likely contributing factor for developing and conduct disorder is conduct disorder is similar to a misconduct. Okay, the behavior is not proper, misconduct basically. Why misconduct? Anyone wants to do it? Misconduct do it because of under any influence, okay, or lack of any parental supervision, especially in less than 18 years of age group. If they have any emotional or psychological issues are present, academic difficulties, any substance abuse can lead to it, exposure, especially from early childhood itself, exposure to a trauma and violence, poor social skills. So out of this, which one are we thinking about here in this case? Here, most likely it's because of an social isolation the patient is having. Okay, misconduct, bad behavior is social isolations. Female sex, it is not very much dependent on the sex. If at all, if they force it, it's more often male sex. 41 years old female, 41 years old male factory worker accidentally consumed and radioactive liquid alpha emitter. He currently denies any symptoms. Next step. So are you at risk here? Yes, because he has consumed. It is there inside his body. It might be throwing out the radiations. So here you are at risk. So first protect yourself by wearing PPE before doing the examination. Then you will be doing wet decontamination. In the meanwhile, always involve the radioactive physicist or radiation physicist. According to MedScore, which of the following would be the indicative of high risk patient who requires an admission? It's an heart rate. Okay, heart rate less than 40, low blood pressure, core body temperature being less than 35.5, electrolyte sodium, potassium, and glucose. I remember as 333, as I told you. In that manner, you need to remember. A 47 years old, known smoker and COPD, has come in with an acute confusion. Steroid, which were recently started by GP, denies any worsening of the shortness of breath or cough. What is the most likely cause for acute confusion? Delirium. Delirium can be because of retention of carbon dioxide or can be because of a severe infection. Here we are not thinking of both because there is no worsening of the cough. So delirium is ruled out. Dementia is a chronic condition. So we cannot think of a dementia in this patient. Whenever the patient hypercalcemia, there is nothing suggestive of an hypercalcemia here. Is it a CA patient? No, it's not a CA patient. Or it is a primary hyperparathyroidism to think of an hypercalcemia? No. Most of the symptoms, what you're seeing here, can be seen because of psychosis. Unlikely. Sepsis, as I told you, again, worsening of the symptoms are not present. You can rule out and come to a diagnosis of steroid psychosis in this question. And it favors the diagnosis because recently the GP has started with. So keeping in this mind, steroid psychosis, yes, that is the right answer in this situation. As I explained you can go back and listen to why not delirium because I have clearly explained. How do you diagnose delirium in the emergency department? 480 is the preferred one in the emergency department for the diagnosis. Haloperidol was administered for rapid tranquilization. 30 minutes later, the nurse observed that the patient was experiencing painful neck spasms, most appropriate to relieve the spasms. It is an acute dystonia. Procyclidine will be given to relieve the spasms here. Aggressive fighting with the officers and has bitten one of them. Verbal de-escalation, which was unsuccessful. What would be the next step in the management? Fighting, aggressive, verbal de-escalation is not possible, then rapid tranquilization is to be done. Best drug here is the ketamine. So ketamine intramuscularly, you can give it if IV line is not there. Known case of epilepsy on levetiracetam. Police called by neighbors due to concern about her strange behavior, unable to obtain her vital signs because she is too combative. Likely cause for acute behavioral disturbance. ABD likely cause they are asking. Nowhere they have mentioned head injury. Nowhere they have mentioned the patient is on any antipsychotic medications. Nowhere they have mentioned the patient is on any SSRIs or tricyclic antidepressants or the patient is depressed. So now we are left with an anticholinergic syndrome and an substance toxicity. So substance toxicity makes more sense here. There is nothing much information to suggest you of an anticholinergic. Why I'm picking up substance toxicity? If you search more about levetiracetam, one of the side effects is having an agitation and aggression. Okay, aggression and agitation is one of the side effects of levetiracetam. So most probably high doses of levetiracetam can cause the symptoms what the patient is presenting. That's why picking up substance toxicity becomes more likely in this situation. A 24 years old woman was found unconscious in the bathroom of a pub by her friends. Friends report that she had consumed alcohol. Heart rate is on the lower side. Pupils are 3 mm and reactive to the light. Rest of the parameters seems to be fine. Slightly low oxygen saturation. What is the next best step they are asking here? Do we know the cause for an bradycardia here? No. Is the patient